Thank you for joining today's webinar presentation. The time for telehealth is now. How and why Mary Free Bed expanded telehealth in under 36 hours. I am Ana Maria Toronto, Vice President of Marketing at Synzi. Jason Peoples, the virtual care champion at Mary Free Bed, will highlight how Mary Free Bed has operationalized virtual care across all outpatient service lines in less than 36 hours in order to address the coronavirus pandemic. All attendees have been muted. If you have questions, please type them into the Q&A feature in the webinar applications window. Today's webinar is being recorded and you will receive a link to the webinar recording this week.
Thank you, Ana Maria, for the gracious introduction. The Mary Free Bed Education Academy is delighted to partner with Synzi to present this extremely important and crucial webinar on our current environment. The time for telehealth is now. How and why Mary Free Bed expanded telehealth within 36 hours. The agenda today, we're going to be covering the state of virtual care at Mary Free Bed, really where we have been on this journey for the last 3.5 years. In addition to where we're at today in the current environment that we're in with the COVID-19 situation and the rationale for the rapid expansion. Also guidance for deploying telehealth and virtual care along with some tips and some lessons learned along the way. In addition to go forward expectations, so what do we look for in the future? The purpose of the presentation is really to provide a high-level overview of the state of affairs with virtual care at Mary Free Bed, along with being able to be selfless and offer tips and tricks along the way with some of our other attendees that are on the line here. So while we want to keep this high level, we will keep it interactive as well. We'll be able to have time for questions and answers toward the end. But also wanted to really focus on, we will not be so much in the weeds with some of the regulations and the reimbursement or the deregulations, I should say. We will touch on that, and we can get to that further down the line. So any questions, we'll just keep fielding those toward the end of the session. So who is Mary Free Bed? Mary Free Bed is the oldest rehabilitation system in the country. Our main campus is on Grand Rapids, Michigan. We also have network relationships with other acute care partners across the state and even across state lines. So we focus on being able to have our patients walk on us. So we are that post-acute quaternary partner to the acute care system. So we are somewhat down the line, but we very much focus on physical medicine and very much function. So our mission at Mary Free Bed is very simple. It's restoring hope and freedom through rehabilitation. The vision is to be the national leader in high-value rehabilitation and post-acute care and develop an integrated system of care. We have set a mission and vision for our virtual care efforts, and the mission is to empower every person to create and share ideas and information without barriers in the support of people we serve at every touch point, with the vision driving this to the accelerated innovation to smart and safely through collaboration committed to patient care and excellence. So the state of virtual care at Mary Free Bed, I have been in the telehealth space for about 11 years, and I had spent the previous 7 years prior to joining Mary Free Bed in acute care. So I worked with a lot of different service lines, a lot of the ology services, let's call them, so neurology, nephrology, endocrinology, neonatology, just to name a few, to be able to look at what we would be able to do to provide access to care to people in different remote locations, whether that was a rural clinic or a critical access hospital or to another partner hospital system that simply does not have access to the resources, the specialty resources that that facility would have. So the bridge to the gap was a telemedicine connection. So traditionally in the hub and spoke model, looking at ways that we would be able to provide services to people in underserved areas. And then looking at where that is being catapulted into the future. So with where we were in virtual care and acute care, taking a lot of those concepts and adapting those to the post-acute space, to acute rehab. So that has been the mission and the vision that we have been on a little over 3.5 years now since I've joined Mary Free Bed. So what we really focused on with our virtual care efforts at Mary Free Bed is really building the foundation. And the key principles that we wanted to focus on is really improving access and communication, along with the integrity and the therapeutic value, and safeguards and security, also being in line with compliance guidelines for regulatory considerations. Virtual care is simply following the trend of all technology advancements and providing a service that people can access in the palm of their hands. Further down the line, as we have developed the foundation for virtual care, we're delivering value through experience and quality and operating efficiency. So this is something we'll touch on a little bit later as well, but really looking at what is the experience of the consulting clinicians and or providers, what is the quality of the care, and what are the operating efficiencies that we can create with developing a virtual care pathway to offer access to care to these people in underserved areas or in areas that they are simply expecting to receive care now. So really focusing on those key principles, putting the patient value first, having a scalable infrastructure, also the security in mind, also engaging the workforce, which certainly impacts the culture of the consulting clinicians and providers, along with meeting what the people and those consumers, what those expectations are, and also looking at what adopting a service mindset will look like. And if anything that we've really come to recognize in the last several weeks is how much technology is becoming a part of our mainstream way that not only we deliver care in healthcare, but also as we have a tremendous amount of people working remotely from home. So the technology will continue to positively drive the digital transformation in healthcare and truly beyond. So how was Mary Free Bed using telehealth prior to the COVID-19 epidemic? So we really focused on our patients that we serve. So I really strongly believe that if you focus on what's best for that person, you cannot go wrong. So we wanted to focus on putting the person at the center of that care and really walk the talk. So within our environment, well, we had recognized that as the person is at the center of the care, the people that we serve, they certainly have limited mobility. A lot of these patients have long-term treatment plans. There's certainly a provider shortage of physiatrists and other specialty services across the board. That's nothing new right now. Also a complex care for the people. And as we are putting the persons at the center of this, often this leads to frustration. So as we look toward the future and we look to really to where we are now as to technology as an enabler, and we understand that in the current retail environment, Amazon is really that go-to person. So if we don't have to go somewhere, we don't necessarily need to get in the car to drive somewhere. We can have things delivered to our house within 2 days a lot of times, and sometimes even that same day. So as we look at healthcare really transitioning from a consumer profile, looking at ways that we would be able to integrate these technologies and use this and how we would be able to embrace this in healthcare. So we look at Amazon as a great example. We look at Uber and Lyft versus a taxi. So the days of being able to hail down a taxi, while we still have those in large metropolitan areas, there's nothing better than pulling out your mobile device and ordering a ride service on demand in the palm of your hand and seeing really in real time where that driver is to where your location is, also being able to provide a time and destination in minutes, and then what that expectation is for the person. So you're seeing a tremendous amount of transparency here with the technology as the enabler. Additionally, if we look at a further disruptor, we look at Netflix versus a brick and mortar building like Blockbuster. Blockbuster had an incredible business model, but they were not able to adapt into the current environment with looking at what streaming services would look like, being able to access all this content. As we are consumers, we're consuming all this content, and where do we want it? We want it right now, or we want it yesterday, and oftentimes we want it in the palm of our hands or on a device of our choice that we can use. So healthcare has traditionally been slower to really embrace this consumer-centric model. So as we look at what our clinic schedules have been in the past, it's been, well, when can we fit you in our schedule, Mr. Smith, not when you would like to receive care. So it's a little bit different mindset today than where we were even several weeks ago. So our industry in healthcare has been disrupted to a point where we have had to recognize that this is a brand new world right now, and we would need to embrace the technology and use that modality to deliver care to people in non-traditional ways. And what's happening is that people are becoming to expect this now, and we were able to see this several years ago with the rise of the on-demand services for healthcare. So you think about an acute care provider that would be able to be accessible on your mobile device or on your computer within 15 minutes for certain acute conditions. Now, these are conditions that most people know what they have already. So think about a sinus infection or a cough or a rash or even pink eye. Being able to have an audio and video interaction with a provider versus having to go into an urgent care or to try to see your PCP. Definitely don't go to the ED. It's very expensive for these conditions that you have already, and you don't want to sit in a waiting room for 60 minutes with 15 other sick people with conditions that you pretty much know you have already and just need that access to care to pick up the medicine or whatever that plan of care would be after that interaction with the provider. So really embracing all the consumerism, recognizing technology as an enabler and driving change. That is what we've been able to do and really wrap our arms around that and adapt with the times. So at Mary Free Bed, the virtual practitioners that we have engaged would be our physicians, our mid-levels, in addition to the clinical psychologists. We have social workers as well. We have an emphasis on physical therapy, occupational therapy, speech therapy as well, in addition to our registered dietitians and nutrition professionals. So in the current COVID environment, all these practitioners are being able to provide telehealth services in a non-traditional way. When I say that, a lot of the patients have been expected to come into the clinic or to the outpatient locations we have. So we have been able to flip the switch and really convert a lot of these patient interactions to virtual care. So the list of practitioners keeps growing. So the goals that we set for our virtual care efforts, we were looking at ways that we would be able to increase patient access. We want to increase that patient engagement. We recognize that a more engaged person is going to have a better outcome. Patient retention, I think, is extremely important to touch on too, because in the rise of the consumerism, what we want and what we expect is the highest level of care at the lowest cost with the best possible outcome. So what we want to do is articulate the why as to the meaning of the engagement, and also want to retain those people to really have them understand the value of physical medicine. And I can share a quick story with my son. He rolled his ankle playing basketball. It wasn't broken, but he was recommended for physical therapy. So we had physical therapy sessions, but after the fourth visit, my son said, "Hey, Dad, I'm feeling well enough that I don't need to go back to physical therapy. Why do I need to do this?" So we were able to share with him the reasoning behind that, articulate the why in his journey to have more engagement and education to help prevent some of these outcomes further down the line were certainly something that was impactful even to a 15-year-old kid. So I look at that as a way that the engagement is just changing so rapidly. Also, the satisfaction was extremely important that we wanted to focus on, not only from our consulting clinicians and providers, but also from the patient perspective. So again, embracing that model of consumerism and having that person be able to be satisfied to receive the care that they need or would like to receive in the comfort of their home on their mobile device or a computer, that's certainly something that reduces a lot of patient anxiety. And it just makes a bit better of an experience to be able to use that personal device. We're talking about psychology as well, where we had a lot of different use cases with people that we connect to, and I like to refer to it as out in the wild, because you don't know where that person is at time of service. We've had stories of patients being in very, very different areas when they are in the virtual interactions. These patients are in different places, and when I say that, I will share with you, patients are in their garage. Some of them are in their closet. Some of them are in their car while they're driving. Some of them are in a break room in an open area. Some of them are in an office at home with no distractions around them. So anytime you deliver care out in the wild, it is truly the wild, wild west, but something we wanted to really wrap our arms around and be able to provide services to the people where they are comfortable and want to receive it the most. Another goal that we really wanted to focus on was the clinical efficiencies with this. So as we have developed our virtual care efforts, we have really built a fantastic foundation, and that is a testament to our operations team that we would have been able to develop operational processes and workflows that mimic or are very, very similar to an in-person interaction and an in-person encounter. So what we did not want to do is recreate the wheel if we did not have to. So simply offering different pathways to patients for a virtual engagement, or if it was for an in-person visit. So we didn't want to create a workaround for that. So that was something that we wanted to reduce the stigma right out of the gate of just one more thing to add to that task list, whether that was from one of our registration staff, from patient service coordinators, or whether it was an MA in the clinic supporting our physicians or other team members. So really the main goal that we drive this point home is this is all about patient access to the right care, the right place, the first time. You know, as we talked before about really putting that person first and really walking the talk of being patient-centered, we put the patient at the center of everything that we do. We have our caregivers really surrounding that patient in this journey. So as we look at this wheel that we've created, we look at the light bulb. That's simply innovations. So we would tie our innovations in really recognizing what we can do differently to adapt to different environments with the technology as the backbone of what we do. In addition to that, we would tie in our data analytics along with some research as well, so that we have a better understanding of what patients' needs are, and also really looking at what the demands are for the people that we serve in different places at different times. So this is kind of that perfect wheel of innovations, technology, data-driven, as well as the research from the data that we've collected. So as we have gone down this journey and being able to connect with people really wherever they are, we wanted to really focus on what is the most personal device that you have. What is the device that you have with you all the time? There's certainly a fear of missing out if you don't have your phone with you. The average person will pull out their phone and look at the screen no less than 250 times a day. Some of these people are looking at the phone just out of habit. Some people are just looking at the time. Some people are looking at the date. It's a fascinating statistic when you think about that. So what we wanted to do is really embrace that model and use the phone as a health tool that people already own. Your phone is the most important device you have with you. And along with your phone, you have tremendous capabilities. It has your sensors in it. It also would notifications and alerts, your calendar. Certainly text messaging is a great function. I think that most people are using text messaging more than they're actually picking up the phone and calling somebody via voice right now. Your phone also has location services in addition to camera, video camera, and most importantly, your phone can also make phone calls. So I think that there's another caveat to this that we would want to branch off and say with the video camera, being able to have voice and video through your phone is extremely important. So think about the device that you have with you and being able to receive care on that. Again, embracing what the consumer's expectations are, and I put the consumers in the person bucket, so I look at that as one and the same. So why expand to virtual care now, and why prioritize our outpatient services? So as the COVID pandemic has really taken effect, we at Mary Free Bed, we wanted to really protect our patients and our staff and the community that we serve. So on this slide, you'll see just an excerpt at what we had captured from the website. We continuously update this. As you can see, this was updated on March 27th. So as we are looking to protect everyone that we serve, as well as our caregivers on our teams in the hospital, the outpatient areas, and also our orthotics, prosthetics, and bionics division, we really wanted to make an impact with recognizing that the people that need to come in for an in-person visit, we really wanted to stratify that and identify those patients that are medically necessary. So as we identified what those patients were, we made an executive decision to go ahead and convert as many people as possible to offering a virtual visit to them. So that has taken across all of our outpatient service lines. So we have broken up our clinic, which would be physician-provider-driven interactions through our physiatrists and our spine and pain program, in addition to all of our outpatient service lines, so including our physical therapy, our occupational therapy, as well as speech therapy, along with nutrition services. We've also had some requests for case managers, external case managers dialing into a certain case with a certain provider with a patient on a 3- and 4-way video call in some instances. That's worked out very, very well. So we really wanted to identify who you have to have coming into the buildings at this point and who could be converted to a virtual visit. So the need for now, the time is of the essence for in-person care, but why telehealth now? It really is a focus on that virtual care. So in this current environment that we're in, I've been in this space for about 11 years, and it's been, I wouldn't say an uphill battle necessarily, but it's been something that I have been looking at to the future for a very long time. And unfortunately, it took an event like this to really slingshot what telehealth is and bring it into the mainstream delivery of care. So along with that, we wanted to focus on what is the opportunity in the COVID environment. So that is really in the improved access. We wanted to expand as many services as possible. Cost efficiencies, this was something that we wanted to dial into as far as cost containment and reduction. Also the increased efficiencies, and again, driving the point home with patient demand. Reducing travel times certainly reduces patient-related stress, and reiterating the point that yes, let's serve people in settings and formats that they demand. In addition to market share, so as Mary Free Bed is looking to be a good steward with our acute care partners, is there an opportunity to be able to provide services and otherwise we wouldn't necessarily had to do that? Also with the brand awareness, this is something that we wanted to be able to share to us in a selfless way. So Mary Free Bed is providing services, but we want to provide our best practices in a compelling way that we can identify any of our partners and any of our would-be partners further down the line with Mary Free Bed putting us on the map and being able to provide some best practices along the way. Also in a COVID environment, first and foremost, we really want to focus on protecting our patients. And we have been able to do that successfully with virtual care with our virtual check-ins. We've been engaging patients in video-based virtual visits, so this would be voice and video interactions with the people that we are serving, and continuing the delivery of care in a safe manner. So again, who needs to come into the physical brick and mortar buildings and who does not? How can we offer those virtual visits to keep our people safe? We're also have dispersed a lot of our therapists as well as our physicians that are working from home right now, and they're able to keep connections in a safe way, not only for the caregivers and their families, but also to the patients. So in a safe and effective way. So these are all things that we really wanted to take into consideration as we operationalize this in a broad scale across the board. In addition to protecting the patients, we have a duty to really protect our staff too. So we want to keep our staff safe. Again, being in a safe environment, being able to provide that care to that person in a safe environment is certainly compelling. We also want to enable our staff to be present for our patients. So as we have expanded this across our therapy services, something that we would want to have just a quick touch point with that patient to be addressing what their needs are in a way that maybe is a little bit more than a phone call. We know that voice and video chat are here. We don't need hundreds of thousands of dollars of video conferencing infrastructure. We can pick up our mobile devices. We can use FaceTime. We can use Skype. We can use Zoom. Lots of different platforms out there that are certainly starting to be propelled into the mainstream to enable our staff to be present for the patients. Also, we want to really focus on reducing the anxiety for the staff. So there is a lot of anxiety out in across the board right now. Certainly our team members are facing this too, as some are working from home. They have young kids at home, being able to protect and mitigate any of those outside variables that may come into play. So we really had to focus on protecting our staff as well as our patients. So we're going to touch on reimbursement real quick. We won't get too far down in the weeds with this, but I did want to touch on this at a high level. So traditional reimbursement for telehealth has really been fourfold here. So Medicare has produced guidelines, as they have for a long time with telehealth, and they have outlined in the guidelines who can provide the telehealth services, where the person can be at time of service, along with the services. So the services are usually the CPT and the HCPCS codes, so those are built. So we have Medicare reimbursement for telehealth. We have Medicaid reimbursement for telehealth. We also have recognized commercial payers will reimburse for telehealth service as well. And for some of those services that are not reimbursed by commercial payers, there can be an out-of-pocket cost for that. So think about that from a consumer perspective, where they may not be having access to their healthcare system, but just want simply a doc-on-demand visit that they would have a compelling price point that they would pay to receive that service. So again, do I want to have a doc-on-demand service? Is it more convenient for me as a person to access a doctor-on-demand service on my mobile device and pay, let's say, $49 or $20 copay versus going to sit in urgent care or in ED? So these are really the wheelhouse of the reimbursement model historically. So in the COVID environment, what we have recognized is that the CMS guidelines have changed dramatically, and they are continuing to deregulate lots of these telehealth guidelines almost on a daily basis. So while I wanted to provide a snapshot of what current CMS guidelines are, and this is something that was as current as yesterday, So we have identified what the type of service is. So we've got the Medicare telehealth visits, we have virtual check-ins along with e-visits. So on the third column over, you'll see the HCPC and the CPT codes outlined for what the Medicare telehealth services are, virtual check-ins along with e-visits. There's also a link at the bottom here that will redirect anyone that is looking for current CMS guidelines as these keep changing, like I said, just about every day. And some of our commercial payers are updating their sites about 2 times a day to use this as a reference, as we are really in uncharted waters right now. A lot of the deregulations have come into play more for the provider-driven services. So traditionally in the telehealth model, it would be the distant site practitioners who can provide the telehealth services, where the patient can be at time of service. The person at time of service has really changed to be able to embrace this current model that we're in, with providing those services to people at home and have a reimbursement rate that is similar or the same as an in-person visit, regardless of the person's location. So that is something that has really jumped forward and reduced a lot of the regulations that we've had before, potentially in a hub and spoke model, but the key was the Medicare, the Medicaid reimbursement for those services. So what was fully needed to operationalize virtual care? So as we were able to operationalize this, I remember sitting in a meeting on Sunday, March 15th. I had just come back from a trip. I had a little anxiety myself as what I was going to be able to get into. Back to my hometown in Grand Rapids. I'm flying into Detroit from Las Vegas. What is going on in the world right now? So as we're sitting in a meeting on Sunday, we were able to really talk about how we would want to operationalize virtual care across the board. So from Sunday to Tuesday morning at 8 a.m., we were able to operationalize this within 36 hours. And what really propelled this was the pandemic that catapulted virtual care into the future, which became now. The ongoing the foundation of the virtual care is these are all the operational processes that we had put into play with the different service lines leading up to now. So as we were able to start small, we were able to build on those successes. But the key to the success was the foundation, not only from the platform and the technology for ease of use, but also the processes and operations with how do we schedule a person for a virtual visit or a telehealth interaction? Do we need to create different visit types? What is the documentation requirements? We had a lot of those pieces in place already, and we were able to scale this with success very, very quickly. So we had a lot of questions, that we were able to mitigate right out of the gate because we had identified the processes with what consent, what are the visit types, what are the codes that we would need to introduce for this. It's worked out very, very well in the clinic with the physician and provider services. Because of the foundation and the processes we had in place for outpatient therapy, those teams were able to really flip the switch too and scale us to where we needed to be. Now with the therapists, in particular physical therapy is when you're thinking about physical medicine, the touch, the feel, we have some manipulation. Some of the therapists thought that they were a fish out of water with, oh my gosh, how do I do this if I can't touch and feel someone? So in these uncharted waters, it's really thinking about innovatively. What can I do differently, and how can me as a clinician have an impact with the patients in a non-traditional way where I'm not as comfortable having a voice and video interaction without being able to touch this person. So along the way, we've really had to focus on what we can do versus what we can't do, and then build on that and have those meaningful and engaging interactions. The strong leadership buy-in across the organization, I really can't stress this enough, because if we don't have administrative support to be able to set the directive and to scale and cascade down to the frontline staff, this is something that would not have been successful as quickly as we did. So we were able to recognize what our strengths were. We built on those strengths and really focused on what we could do and really learn along the way. There's a tremendous amount of information that's coming out every day, as I mentioned, CMS, the regulations, or the deregulations rather, but we have lots of team members together as you have a department that is really focusing on championing this, but it always is a we effort. So we have really leaned on some of our outpatient leadership as far as the operational leaders to help operationalize this and cascade those communications down, including instructions and user guides to the people that are going to be using this, along with having some references for the patients as well. So we know technology is fantastic. It's even better when it works. So in those instances, we wanted to provide as much information as we could for the quick troubleshooting, and we have certainly come a long way, and we are simply moving forward with all the lessons that we've learned, and will continue to adapt to the current environment. The strong leadership support has been very, very important, being able to champion this. In fact, a lot of our peers, as we were looking to go down this virtual care pathway 4 years ago, that their telehealth has not been adopted very much in the acute rehab space. So we have been trailblazers and pioneers in this space. We have best practices, and that was really one of the purposes of the webinar, was really to share that with the group so that we can be selfless in a way that we can help as many people, organizations, and patients as possible. So engagement was another key piece that was very, very important to us. So we wanted to have our providers be engaged with this as well, instead of having, well, would you like to do this, or this is how we're going to do this as far as a patient interaction. So having our consulting clinicians, our providers, our psychologists, we really needed them to help champion this as well. Patients will listen to their providers, believe it or not. And this quote is great from Dr. Dermeyer. She outlined that telehealth bridges access to care gaps, connecting individuals in different geographic locations. So it doesn't get much simpler than that. And she's certainly been a champion with us along the way and continued to be one of our best practice providers across the board in the psychology space. So what were the results? What were the learnings? Well, we had a few things. So one of the first pieces that we had to learn real quick is how to adapt. How do we adapt to this new environment? Our world was shaken upside down. All of a sudden, telehealth has jumped over and become mainstream delivery of care. So how did we do that? Well, we had to recognize that we had to adapt pretty quickly. So along with adapting, there was a learning curve with this too. So not only from the provider perspective, but from our patients too, who had been coming in for certain in-person visits. You can think about somebody coming in as for a physical therapy appointment, and all of a sudden they're not able to do that. So how can we provide care to a person at home when we haven't had time to react and really plan for that? Also with the providers thinking about, how can I do this from home? How can I do this in a different environment in a clinic space? So I think about a great story that I could share with one of our speech language pathologists, that her first virtual interaction was 2 weeks ago today with a patient who had just turned 5 years old that day, and she was able to have the voice and video interaction for 37 minutes and was able to have visual cue cards that was able to have this interaction with patients and mom. So to me, with all the work and being able to lead these efforts and to be on the front lines, literally in the trenches, but to support the team members that are providing these services, that to me is the most gratifying part, because all the work that we put into this, it's really about that person. So when you can have that meaningful interaction and you can witness that and you can see the smile on the patient's face and the graciousness of the parents that are just so thankful that treatment doesn't have to stop. So why as we, the healthcare system, should we stop doing this? So again, it's catapulted into the future, but we're recognizing this and we're building on these success stories. So the learning curve also ties in with the patients and the consumers. So this is something that they have come into visits for, but now they're going to be at home receiving these services. Also looking at the learning curve with expectations. Expectations not only from our providers, but from our patients and consumers as well. Things are changing all the time, and we recognize that. And we've learned a long time ago that in healthcare, that if there's one constant, it's going to be change. A lot of healthcare systems, even the ones that I've spoken to in acute care, some of them have not operationalized telehealth yet on a broad scale. So there are some people that are a little late to the game in this, and it's a great experience for us as in Mary Free Bed to be on the forefront and be able to drive these ideas and these initiatives and help as many people as we can, with the expectations that it is an unsettling environment right now. People are very, very anxious, and those people are not only our patients and consumers, but they're also our team members. So we had to meet what those expectations are to make sure everybody feels comfortable, everybody feels safe, or as safe as they can be in these uncertain times. So one of the lessons learned, we'll go down this list, is really taking the physical out of physical medicine. This has required a significant shift in the mindset of our consulting clinicians. So again, if you can't touch and feel and manipulate, what can you do? So in this world, even with our physiatrists that have had They've been able to connect with people from afar. Sometimes they'll have people that are able to act as their hands-on and be that translator in those moments, in those interactions at home. Also lessons learned if we wanted to focus on what the integration of virtual care into the existing workflows. So this was really tied in with our clinical efficiencies and our operations and building from the foundation that we had established already with different team members and operational leaders across the board. So we really, again, wanted to focus on what are our current processes, how do we integrate virtual into our current processes so then it just becomes part of the workflow. So we didn't want to create something very cumbersome that we would have to create our own virtual care workflow that was vastly different than any in-person interaction, tying in with the registration process, let's say a check-in from that patient from afar. What do our medical staff, how do they do this? So being able to integrate this into a way that makes sense and is somewhat familiar has been another lesson learned and certainly a key to the success. Other lessons learned, really, highlighting some of those examples, especially with the speech one that we just touched on, is starting small and building on those successes. Those successes have helped drive the awareness. It also brings a certain amount of excitement and adoption for the scalability. So with some of the clinicians and the physicians in particular, there's a little bit of competitive spirit engaged here too. So, well, Dr. So-and-so is doing this. I didn't think I could do this. Well, maybe if they're doing it, maybe I can do that. So I like to really build that competitive spirit and to think about things that we haven't done or maybe somebody else is doing it. So there is a cool factor with this too, but what's happening is it's becoming ingrained in how we are interacting with people and we're receiving that care. So other lessons learned, we're going to talk about support here real quick. So you've got your person on the left there, they're frustrated, they're at their computer. Again, we touched on technology is great. Technology is even better when it works. So the most important thing is to really keep calm in the moment when things don't go right, just keeping a level head, being able to provide as much reassurance and support, not only from a staff member standpoint who is providing the services, but also to the patients that may have some technology issues. And then, looking at, as we're focusing on mobile devices, it seems to be a much cleaner experience. There are a lot of restrictions that people don't recognize they have when they use their computers. So you think about when you go to the internet, somebody at home says, hey, I'm just going to go to the internet. Well, they're going to launch a web browser and they're going to go to the internet and type in whatever web address that is. They don't recognize that they're launching Safari as the web browser or Google Chrome as the web browser, or they're using Firefox, or they're using Opera or something else. They're just going to the internet. So as we want to provide as much reassurance and advice and recommendations to the person being able to receive the care on said device, but also reassure our team members that we have support, that we can help you along the way for sure, as long as from an IT perspective as well. And the important piece is to keep calm and pick up the phone. So there's nothing wrong with being able to pick up the phone and touch base with that patient, or even if it's from a support standpoint. I have had countless interactions with our clinicians and providers and helping them troubleshoot, also provide some guidance from IT to certain things that they can look for, and also vice versa. So IT has provided me some examples of some tips and tricks that I can incorporate on the front lines as we are working with clinicians on the front lines, our patient service coordinators who are scheduling the people. Anytime that there is an update on certain systems that are pushed out, sometimes things break down the line. So again, we just need to stay calm and we need to think this through and be able to provide an excellent level of customer service and truly be the solution in those times of panic. So from a patient perspective, again, we just want to keep calm, pick up the phone. We can just have an audio touch base with them if we need to. So what does Mary Free Bed expect to happen next in terms of virtual care? So what is on our radar right now is really something I've been looking at for a number of years, but there's a nice graphic here, and this is dated at this point. This is from 2018, but if we're looking at historical information from the telehealth adoption, you see where we are with the bullseye in 2020. We're at a 50% adoption rate. Historical data is what we would expect. We're going to see this trend rise, and what I can share with you is on the next slide with what we have been able to do with our small efforts with our virtual results for outpatients. So again, as Mary Free Bed started small with our outpatient efforts based on the CMS restrictions that were in place on who can provide the service, where the person can be at time of service, and what the CPT and HCPCS codes are. So we were able to really scale this with our physicians and some of our therapists. So we looked at in fiscal year 18, we had 131. Fiscal year 19, we certainly increased that to 631, and we were at 949 fiscal year 20. And the data that I pulled from since the COVID pandemic rather, from March 16th to March 27th, we had 1,095 virtual interactions, and most of those, all those interactions were over 5 minutes. So as we're looking at ways that we can, again, engage those people at places that they are comfortable with and having those engaging interactions. So what I did is I took out all those quick test calls, all those 1-minute try interactions. These are true more than 5-minute visits that we've had, and we've had a lot of success in really expanding on the platform's capabilities to be able to not just produce a voice and video interaction with that person, but also be able to bring in a third and fourth party in some instances. So having an interpreter brought into the mix in real time has been extremely beneficial. In addition, we have had a lot of requests and have satisfied those requests for external case managers joining a video session with a therapist or with a physician or with a provider as a three-way video call. So that's worked out very, very well too. In scaling that, we also were able to incorporate our multidisciplinary clinicians for our pain program. So we have PT, we have OT, we have psychology, we have physiatry, all in the mix that have been using 4- and 5-way video calls, and sometimes with those patients too. We've looked at this as a way that we could also have team conferences. So we just keep building on those established use cases and leveraging the platform. So it's certainly compelling for us to be able to leverage a technology platform and scale with us along with the use cases that we have expanded to. In fact, last week we had a request from our spiritual coordinator who would like to stay connected in this time. So he has recommendations from his provider to stay home. So he would like to have a presence in the hospital, not only from the patient perspective, but also for the staff. So while this is an engaging, meaningful interaction, it's something that I hadn't even thought about before, would be bringing in our spiritual care coordinator to be able to have those patient touch points along with our staff members that would like it as well. So the use cases, they keep expanding, and you hear about the platform. The pipeline is very easy to build. To me, the technology has always been the easiest part. It's been the messier part with the rules and the regulations and the restrictions. But as those loosens, we just keep seeing tremendous amounts of opportunity, different use cases that we can roll in that are established that, again, we can build small and build on those successes. So further down the line, as we look at what is coming, so we have focused on what a smart hospital concept is. And there are some key principles that we have focused on in integrating into the smart hospital concept. First is access. Safety is extremely important. The quality of the services that we provide, the reliability, not only from a technology standpoint, but of the services. We want to have that patient retainment, and a lot of times, especially in the O&P space, we have patients for life. So we want to provide the best access, the best safety, the best quality, and we need to be reliable with our systems and our processes. Engagement has certainly been something that has been very beneficial for Mary Free Bed as we have started the virtual journey, but expanding that to that smart hospital concept. So education awareness is very, very important. Digital front door, so different tactics that we could be able to incorporate as people are coming in, or virtual check-ins. Things like that. Verbal consent can be accepted, or if you're looking at ways that we would be able to have paperless documentation, what would that look like? Also leveraging mobile health. So today in the mobile health space, there's over 400,000 apps available in the Apple App Store and Google Play. That's a tremendous amount of access to mobile health right there in the palm of your hand on the device that you have. Also, we've seen people leveraging their patient portal more, not only for communications and updates, but also as a pathway for people to be able to access certain portions of their medical record, be able to send secure messages, and oftentimes what I'm seeing in acute care is a drive to use the patient portal as an entry point for that person into the system to be able to receive care in a virtual setting. So there's assumptions that are based on that, because as I'm looking at consumers versus patients, the patient portal is an assumption that you are an existing patient of that system and have a patient portal to access that functionality. Not all people are patients of a system, so you look at that from a consumer perspective. But we want to be mindful. We want to leverage the platforms and the technologies that we have available and accessible with us today. And certainly the impact. So this is a fantastic quote from our Chief Medical Officer, Dr. Jakubowski. Telehealth is another means that we can reach out and extend the expertise that is in the quaternary rehabilitation facility and extend that reach to the rest of the state and beyond. So that's something that we have been able to really embed into the culture and have more traction as we've been moving forward, and certainly something that we can share with other healthcare systems as we can minimize the distance as a barrier for certain specialty services. So we are happy to partner with you to do that, and we can see what the opportunity is and really operationalize this in a strategic way that is beneficial for all parties and certainly for the people that we serve. So as we move forward with this, really this is about asking for Mary. Mary Free Bed can be virtually everywhere. And your rehabilitation is right there in the palm of your hand, whether that's on a phone or whether that's on an iPad or your computer. So as we look to catapult this forward and looking at virtual care being in mainstream delivery of care, now the evolution is here today. So it'll be very, very interesting to see what sticks when the guidelines with CMS and what the guidelines are in the next 6 months and 12 months. People are expecting to receive care in the palm of their hand right now. Regulations have been slower to catch up. So it's a very exciting time. It's very unfortunate that it took an event like this to really propel virtual care, telehealth into the mainstream overnight, essentially. It's something that I'm sad about, but again, to me, who's lived in this space for so long, have looked at the different use cases and being able to provide these interactions in a way and the evolution using your mobile devices, it's fascinating. We're all being forced to think differently about the way that we work, the way that we receive and deliver care, and actually everyday life. So as we have more people that are at home and not going anywhere, using services that are more on demand. We're seeing restaurants delivering right to your house now. That's not something they did several weeks ago. So it's an interesting time for sure. So I appreciate the time, the opportunity to share a little taste of my world with this group. And if you have any questions, I thank you very much for your time and look forward to fielding anything that I can in the time that we have left. So thank you, Anna Maria, and thank you for the Cincy team for partnering with me and being able to share a bit of my world and what we've been living through literally in the trenches for the last 2 weeks.
Thank you, Jason, for highlighting your experiences and sharing your insights regarding this very timely topic. We have a couple questions from the audience. One is, how does Mary Free Bed protect HIPAA when patient is not in a private area during the call?
So in the instances with HIPAA, what we had focused on is that we wanted a HIPAA compliant platform for two-way audio and video communications. So we know what the guidelines are for HIPAA. There are certainly encryption standards. So with any platform that you would be looking at, we wanted to make sure that the platform in particular was of HIPAA compliant. So we do have the paperwork taken care of on the back end with our partner with Cincy. So we have a business associates agreement with Cincy. So we do share some risk in that regard. But we can also provide recommendations to the person being served wherever they are to be in a quiet area, to be in a room with minimal distractions or no distractions. When we deliver care out in the wild, it is truly the wild. We don't know where they're at. We don't know who else is with them, but we can provide those recommendations to the best of our ability. Like I said, we've had people in the car driving while they're having these interactions. I certainly don't recommend that, but something for somebody to be able to pull over or to be able to have that interaction where they're comfortable is certainly important. So the HIPAA compliance where we really focused on was the platform itself. We also obtain consent for any of the virtual interactions, whether that's through verbal, and we certainly document that too, so that's reflected in the documentation for any of the consulting clinicians. We have a double verification on the front end with the person being converted over to a virtual visit from an in-person visit, so that's also taken care of by our registration staff.
Thank you. The second question is, are the auto no-fault insurers establishing any reimbursement guidelines? Is this something that Mary Free Bed is aware of?
That is something that we've been watching pretty frequently. Again, the regulations are coming down the line, so this would be more for the state of Michigan and how we have been able to manage this. As of right now, as we have partnered with our compliance department who are looking at the regulations, I swear it's almost every hour at this point, we have not seen any restrictions with auto no fault at this point in time. Historically, they have been very, very open to providing reimbursement for virtual care services. We expect that to remain same in our current environment, but something we're certainly keeping a keen eye on as regulations keep changing.
Does Mary Free Bed maintain a patient portal?
Mary Free Bed does maintain a patient portal. So in our current Mary Free Bed environment, we have our clinic, which would be our physician outpatient services. So we use a medical record called Athena for our clinic services. So there is a patient portal that is with Athena. For the hospital as well as outpatient therapy services, we use Cerner in the Community Works environment for that medical record platform. So we have established a patient portal that would allow a person access to for certain pieces of their medical record information, be able to send a secure message to a clinician or to somebody else on their care team. We've also looked at and we've expanded to be able to request medical records through the patient portal as well. But we are not providing any virtual services through the patient portal today.
Are PTs, OTs, and SLPs only able to do e-visits?
That is a great question, and we have been looking at the regulations or the deregulations as they've been coming through. So unfortunately, as we've been looking for certain guidelines for PT, OT, and speech, e-visits seem to be the easiest bucket to code for today, as they're, I'm trying to remember how they have it broken down. Is it a non-qualified, non-healthcare provider, something like that for the e-visits. So that has worked out well so far. We know that Blue Cross Blue Shield in Michigan is going to reimburse for those services, but Blue Cross Blue Shield is so different in so many other states that it's almost a query from that payer and the contract that the organization would have with their payer type. So e-visits, that's what we've established today, but that very well could change in the next 2 weeks or the next tomorrow. So again, we're looking at these guidelines every day, and we want to provide our clinicians with as much information on the front line so that we are coding this the right way and trying to remain in compliance. So we are keeping a very, very close eye on that every day. In fact, I just met with our compliance officer at 11:15 this morning to see if there was any new updates, even going into this webinar session today, to provide as much accurate information as we can. So I would recommend that we look at what the APTA guidelines are and seeing what those changes are. If there's specific questions for payers, then that may be a question the organization would take up with their payer contracting or their compliance officer.
How has Mary Free Bed older patients as well as older parents or guardians got on board with the use of technology for service delivery?
That's a great question, and one that I've heard pretty much my whole career in healthcare, which has all been in the telehealth space. So yes, we do think about having a 72-year-old person at home who can use Facebook, but they don't know how to download an app. So that was the key to the flexibility of the platform and having the ease of use with that. So the idea that we've been able to operationalize successfully is really using that mobile device as the point of contact. So the way that our process works is that we enroll that person in the platform, and they are able to receive a text message with a link in that text message that redirects that person to the App Store or Google Play to download the Care Connect app. That person would then need to validate with their date of birth for that unique token into Mary Free Bed's virtual care environment. Once that person has successfully logged in with their date of birth, we're able to initiate a video call to that person. So we've tried to make it as simple and easy for everybody as possible. Now, on the other side of things, I just worked with a patient on Monday that we had a great session with a virtual visit with before. He wanted to use his computer, 78-year-old gentleman, and he was using his Mac at home. He's trying to launch Safari. He's trying to figure out where Google Chrome is, as we recommend, a certain browser because we know it's tried and true. So after about 15 minutes of troubleshooting, the patient was very, very patient. He was very tenacious, and he said, I'm going to figure this out. So we have those people out there that are really wanting to figure this out for themselves because in a way, they're forced to at this point. So, as we talk about user adoption at certain age demographics, We like to refer to it as, yeah, if you can download an app, you can certainly have a voice and video interaction on here on your mobile device. So again, it's not as much of a foreign concept, but there is some patience in being able to walk that person through what the process is. And even for tech-savvy people where it comes second nature, we want to be able to provide that excellent level of customer service that would help somebody along every step of the way, and also provide documentation that helps those people along the way, even as a simple user guide with, this is what this looks like, this is what you can expect.
We have a few questions regarding reimbursement. The first one being, does Medicaid cover virtual pediatric visits for outpatient speech, occupational, or physical therapy in an outpatient private setting?
So I think that would go back to the current codes that we have been looking to introduce for the e-visit codes right now for PT, speech, and OT. So we want to follow what those guidelines are. I have not seen the Medicare reimbursement for therapy services yet. Again, that's changing. There's certainly a push to see that happen, but we have not seen that yet in our payer mix. In particular, a lot of those telehealth services, the deregulations have been focused on the historical distant site practitioners that would be able to provide those telehealth services. So your docs, your mid-levels, your clinical psychologists, and registered dietitians historically have all been able to provide telehealth services with Medicare reimbursement. You hear that there's no therapy on that list, and that follows true today. So we have been very creative with being able to figure out how we can provide services and code it the appropriate way. But also we looked at this as something that for us at Mary Free Bed, we wanted to provide as much access to care and provide services as possible. So our stance was, if a person needs help, they need care, then that's something that we would be willing to figure out on the back end, that how the billing and the reimbursement would work, because if we don't provide a service, there's no chance of any reimbursement. So if we do provide a service and roll the dice and follow the guidelines with what is in today or what will be down the line, there is potential for reimbursement for those services. So that's something that Medicare is a little slow to the game on, but again, we're hoping to see this momentum move forward. I think I saw United Health is reimbursing for virtual care for speech, PT, and OT, but not Medicare yet.
Okay. What about some insurances reimbursing for outpatient pediatric virtual therapy visits, such as BCBS or Priority Health?
So Priority Health has been for outpatient for therapy services. That's not something that they have traditionally reimbursed for today. So that's something that we are checking with our payers consistently with any of the outpatient pediatric services that are non-therapy driven. Let's say it's from a provider or a mid-level doctor are able to provide that service. It's the same level as reimbursement as it is for an in-person visit for those professional services. So carve therapy services out, look at that from a physician provider perspective. Those will be reimbursed at the same rate as an in-person visit. And for the Michigan team here, Michigan has passed parity laws years ago that stated that the reimbursement for telehealth services would be the same as an in-person visit. So the commercial payers are following what that is. So that is something that's been a benefit for the residents in the state of Michigan.
Great. A couple other questions regarding the telehealth physical therapy. Is there any insight into payers adjusting in the future for more reimbursement of physical therapy?
Yeah, I think there has to be, and I think that that's what we're looking at right now, again, with our compliance officer and identifying what's the best way that we would be able to provide these services, but also remain in compliance with the coding. The documentation is going to be the same, whether that's an in-person visit or if it's a telehealth visit. In the documentation, you would just reflect that this visit occurred via telehealth, and you can identify where the person is at time of service. So that workflow is the same, but the question is, how do you code this and what's the reimbursement for that? So we have been very creative with what that is and are looking at those e-visit codes today that we've implemented and developed that into the workflow, to the note for the clinician, but also we're querying our payers all the time with this. So that's what we're looking forward to, hopefully some guidance from CMS that'll be pushed out to the other payers, because unfortunately there's so many payers that have their own ideas and their own payer contracts with those organizations that differ. So being able to recognize all of that is something that we're doing the best to keep our arms around this and keep an awareness, but knowing that everything is very fluid. We've seen some regulation changes within the last 24 hours, for example, outside of therapy services for virtual health. So there's certainly a push for this. I think we're going to see more of this in the next several weeks, or at least that's my hope, because the environment that we're in today is not going to change. In fact, I think it's going to be a bit worse for the next 4 weeks as we get more confirmed cases, simply because there's more testing and more people that need to have these services. So how do we do that in the most functional way? So I wish I could answer that with a definitive, this is what this is, but we're, like I said, just keep an eye on what CMS guidelines are and what those payer relations are with your organization.
Great. Thank you, Jason. There were a couple other questions that we will actually respond to the individuals one-on-one. So just feel free to be patient with us, and Jason or myself will get back to you, as well as we'll be providing within the week a link to the webinar recording. I want to again thank Jason for all of his time and effort in delivering this valuable webinar regarding how Mary Free Bed has been able to expand their use of telehealth and virtual care within 36 hours. Today's session was sponsored by Synzi. We are a HIPAA-compliant virtual care platform with telehealth apps which enable staff to use video, secure messaging, text, and email for clinician-to-clinician and clinician-to-patient communications. Throughout the episode of care, clinicians use Synzi to engage patients with video-based virtual visits. As Jason alluded to, multiple participants can be brought into these video calls, and that means additional specialists, family caregivers, a medically certified interpreter, a pharmacist, etc. These touch points are extremely critical, especially during the current pandemic, as patients may be denying in-person visits, or they're quarantined, sheltering in place, or practicing social distancing. Also, rehab facilities and clinics are increasingly restricting visits from external staff. And video-based virtual visits ensure that your patients continue to receive your organization's care and support. With Synzi, clinicians also engage patients above and beyond the video-based visits with condition-specific messaging. By pushing out a cascade of patient-centric messaging, these touch points are increasing adherence, reducing the risk of readmissions, and enhancing satisfaction for both the patients and the staff. Visit Synzi.com to learn how to safely continue delivering valuable care while minimizing further disruptions to your organization, especially during this time. This concludes our presentation today. Thank you for your time and interest. Stay safe and be well. Take care.